Bore da, good morning. Welcome, croeso to the 8th session of the AHP Cymru Conference 2022, Extraordinary Times, Extraordinary Practice, and People as well. It's an honour to chair today's session. For people who don't know me, my name is Gethin Harris. I am newly in post as the AHP Person-Centred Rehabilitation Lead, and that role is based within HIW. This session, I guess, is a starter point for us as an AHP program to start exploring the value-based outcomes, value-based measures for AHPs and for the wider rehabilitation community in general. I hope, and I'm sure that many of you are aware of the Rehabilitation Framework and all the good work that's been done to date by numerous colleagues. Hopefully, as well, you may be aware of my colleague, Ross Noel. He is our Rehabilitation Leadership Fellow and is doing some great work on reviewing the framework at the moment with lots of stakeholders, potentially people who are listening in today. If this is something that's relatively new to you and something that you'd like to be involved with, I know Ross is going to say hello in the chat at some point and maybe pass on maybe the best way to contact. But for any sort of, for clarity, really, feel free to contact us on the generic email that we've got on this holding slide. If you can see that. When we move away from the slide, if anyone needs it, we'll put it back up on the chat. So I say it's an introduction to rehabilitation, the Rehabilitation Framework and a value-based approach, but over the last 2 weeks, it's been absolutely fantastic to see value in the sense of introduction to the Healthier Wales documentation, the link to the AHP framework. We've had some great discussion about outcomes from individual teams and also from a national point of view. We've seen examples through mental health already with regards to recovery through activity with OT programs. And of course, more recently, we've also seen a huge piece of work where everyone has come together with regards to developing the Adferiad work, in particular relating to long COVID and introducing outcomes such as EQ5D5L. And from a national point of view as well, we've seen over the last week or two the importance of digital and the importance of data. And we've also seen the importance that we need to have leadership at every level, and we need to be in that position to feel co-productive in how we go about things. And hopefully that further discussion will happen today. Finally, yesterday, it was very lovely to, as a nice introduction to this session, I feel, was the ICDM team from the HIW team talking yesterday about what is a measure and not necessarily a typical thing that we might have previously thought more about with regards to treating a disease, but more so making sure we have that importance to the person and their social obligations and their vocation. So the session will be interactive, hoping to use Mentimeter and something called Jamboard, if you're familiar with that. So please keep your tech to hand. Big thank you to Lauren and Abby and Wendy as well, actually, who's been helping a little bit with that from these sides of things with regards to the chat and the tech. So big thank you to you all. And feel free to engage with us in social media. So the main hashtag we're using for the conference and the sessions is the AHP_Cymru, which again is on the holding page here. So our speakers, I'm sure, will be very eager to speak to you today after they've done their talks and have a bit of time for questions. If for some reason there's anything in the chat that we've not responded to, I do promise I will trawl through it after the session to make sure we've answered everything. But if you do have anything directly you want to contact the speakers about, or myself or the team, please use that email that's come up in the chat. So for housekeeping, the event is being recorded. The session we hope to keep to 60 minutes, as I appreciate you've all got other bits of work to go to, and you may like a cup of tea in between. Feel free to keep your cameras on. Appreciate that's not always achievable with regards to technology, but it's just nice to know that you're all there, safe and well. And for now, if you keep your mics on mute, as you will have opportunity to join in the conversation. But if you could raise your hand using the raise hand icon, not the real hand, for any questions. And hopefully we'll have some time at the end for a breakout room, which will give you that time to have that free-flowing conversation as well. Right, okay, so next slide, please, Lauren. So aims of the session, the Rehabilitation Framework, hopefully that front cover of that document is something that's relatively familiar to some of you. It is, the link is in on the web page, and it is a resource for you to have a look at in your own time. We will hopefully have a discussion about value-based outcomes. Appreciating that language might be different for some of us, so we might need to just have a think about that, and maybe as part of our conversation. And we will then have an opportunity to hear about two great services, and have a think about how they've successfully introduced and embedded processes pre and during and post pandemic. And then hopefully we'll have time to come together to have a think about what our next stages are to improve a value-based approach and value-based outcomes in our services and for ourselves. And we'll use that as a resource to see where we go next with this type of conversation. Okay, next slide, please, Lauren. So we're going to move to Mentimeter now. So this is we'd ask you to go to the Mentimeter site. You can use the QR code and then type in this number. There will be two questions for you. The first question is just to ask you about your feeling about how important a value-based approach or value-based outcomes are. So we'll give you some time to access that. Any problems, feel free to let us know and we'll see what we can do in the chat. Okay, so numbers are coming through. I think overall that's pretty good, that we recognize, we all feel that generally a value-based outcome approach is extremely important. So the next question, has everyone got enough time to get in and access that and answer that question? Yeah, okay. So let's move on to the next question. So what about our confidence in the use of value-based outcomes? Now, this may be slightly different, and I think we all recognize the importance, but sometimes application can be a little bit more challenging. A bit of a spectrum, but we're identifying that maybe we would like to know more and have a bit more confidence in how we move forward. So hopefully with our inspiring talks coming as well, and maybe some work that we're going to be doing over the next few months, we can look at maybe how we support that, especially with information we might gain from today's session. Okay, thank you. Right, next slide. Oh, Lauren's ahead of me. Thank you, Lauren. Okay, so just a quick bit of context really to the Rehabilitation Framework. The framework was developed to assist in planning for anticipated demand and for rehab and recovery related to the pandemic. It was identified that 4 discrete populations at the time were likely to be impacted. As I mentioned earlier, Ross is doing some great work with regards to reviewing this with colleagues, and as a result, then we might get some additional information, be that related to populations that are slightly differently impacted. But that work is ongoing, and we'll look to release sort of the update on that in the near future. Ross has another 6 months, I think he does, left on his placement. So yeah, plenty of work to be done. And again, just to reiterate, we welcome you to be part of our stakeholder sessions for that. Can I go to the next slide, please, Lauren? Okay, so just thinking about value-based outcomes. So prior to my role, I did a bit of chatting around to everyone in and around rehabilitation, trying to understand the role a bit better. And also we've got some great resources in value in health in the NHS here, and other areas such as Health Foundation and so on. And I think the conclusion really that came to me was that when we think about value, we're looking at a focus on delivering outcomes for people over process, targets, and financial measures. And of course, cost will be essential, but when we're looking at costs, very much looking at that social return on investment in that approach. So let's just link a value-based outcome approach to the framework. So thinking about evaluating the impact of rehabilitation services post-COVID, we look at Hurst et al. That was referenced within that document to state that a value-based approach is equitable, sustainable, and transparent use of the available resources to achieve better outcomes and experiences for every person. But particularly to a link to the framework, we're looking to engage in better data, better evidence, and that multidisciplinary engagement approach. So without, I'll stop talking, basically, and we'll move over to slowly introducing our speakers. So first of all, we've got David Hughes. Now, David had told me I was allowed to introduce him as Di the Pod, but I'm not going to just do that. I think David Hughes, the MBE Clinical Lead and Manager for Podiatry Orthotics, MCAS, and Persistent Pain Services in Swansea Bay Health Board. David was an AHA Award winner and Welsh Government Award for Prudent Service to Redesign, and many other accolades as well. I think speaking to David before about today's conversations, I think what really struck me was the ability to embed making every contact count, co-productive approaches into practice and to support people in that area, and also interested in the work that he's done from a national point of view as well. So I will allow David to upload his talk now and take over.
Bore da pawb, good morning everyone, and thank you for the opportunity to share some of our lessons from Swansea Bay Podiatry and Orthotics Life and Limb Prevention stories so far. Hopefully some of these lessons will be easily translated and where it is directly linked to the rehab framework, I hope that I've pointed that out. So if everybody can see that slide now.
Yeah, coming through clear.
Yeah, great. Okay, thank you. So our story was first driven by the prudent principles and began with embedding making every contact count across our infrastructure. This followed with us measuring behavioural change as our KPI following our brief MEC interventions. Thirdly, we knew all too well our increasing population need, specifically in relation to lower limb crises. Since time immemorial, we were aware of the literature that 80% of lower limb crises leading to amputation and associated morbidity and mortality were preventable. The questions always remained, however, what were we doing so wrong, despite continuously increasing and unsustainable efforts to do more and provide more and more to our patients? Our paternalistic model of care was not working for us or our patients. We therefore took a multidisciplinary approach through root cause analysis of all lower limb amputations undertaken in Swansea Bay during the year 2015. The lessons learnt from the RCA focused our attention on the new priorities of co-production, self-management support, and patient activation training of the entire workforce. To facilitate co-production and effectively support our patients and caregivers to act as equal partners in their health, we introduced a pre-consultation questionnaire. This ensured waiting time was not wasted time in ascertaining what was material to individuals and what problem-solving skills they had in order to engage in their care and outcomes. This work has led to 3 national adoptions. Firstly, the All Wales Agreement to embed a patient activation measure or problem solving within the UK-wide diabetic foot guidelines, putting feet first. Secondly, the introduction of patient activation levels to the National Podiatry Taxonomy of Need and Risk. And thirdly, the All Wales adoption of the Validated Patient Activation Measure, or PAM, for 10,000 patients living with diabetes across Wales. So what was the impact of embedding MEC? Well, we ensured that all staff at all levels were trained in brief interventions to develop a workforce-wide culture of empowerment. We visited, revisited and reinforced our 30-second 2-minute interventions at each follow-up and record electronically where behavioural change has been confirmed. MEC triggers have been embedded within our own electronic notes template to ensure every opportunity is taken and not missed. For example, dates of birth, age-specific immunisation and discussions such as HPV, shingles and flu are always triggered. Next was our MDT root cause analysis. Not only are 80% of lower limb amputations cited as being preventable, but Swansea Bay, or ABM as it was then, had the highest recorded amputation rates across the whole of Wales. Using the Patient Safety Agency Contributory Factor Checklist, we undertook a gap analysis to gain local intelligence on what factors needed addressing most to make the greatest impact across our population. You can see that amongst each of the care and service delivery problems we identified, the third most prevalent contribution to crises were patient factors. In line with the literature, over 80% of the amputations undertaken in our health board in 2015 may have been preventable, with nearly half of these being due to low levels of patient engagement in their own care. This focused our attention on a whole service approach to developing co-production and activation skills. Aligned with the Hibbard model of activation and Health Foundation co-creating health toolkit, we supported the team with improved understanding of role congruence, with patients at the centre. Drawing on the toolkit, we have taken a workforce-wide approach as teacher, manager and coach, supporting patients to act as equal partners in their care. The Hibbard model of patient activation underpins our practice. Activation, or problem-solving ability in a patient, is made up of the patient's level of knowledge, skill, importance and confidence to act as equal partners in their care. Higher activation is commensurate with more positive behaviours, improved satisfaction rates and improved preventative, restorative, supportive and palliative outcomes. How many of us here always do something that we know is not good for us? We know that it's not good for us. Do we have the skills? Most of us probably do have the skills to be able to change that. So why don't we? Perhaps we shouldn't be focusing, as we have done historically, on knowledge and skill, and look more towards how important is it for us to make the change that we need to make in life? How confident are we? And sometimes there's a juxtaposition between importance and confidence. It may be very important, but our confidence to do something about it is very low. Conversely, it may not be important at all. At any point in time, we should expect nearly a quarter of our population to present with lower activation levels. Identifying individual levels enable us to provide and prioritise greatest need. These lower activation levels are commensurate with costly hospitalizations, longer lengths of stay, readmissions, long-term dependencies on services, and reduced mobility and independence. If I haven't succeeded in inspiring an activation-based model of care as simply doing the right thing, then perhaps we need to consider the approach as a duty rather than a choice. Paternalism breeds dependency, encourages passivity, and undermines people's capacity to look after themselves. Paternalism may appear benign, comfortable, and reassuring, but it is a hazard to health. Our professional standards of conduct, performance, and ethics clearly set out our duty of care. We must help service users to maintain their own health. If what we are doing is not working, we must look at what evidence-based changes we need to make in our practice in order for that help to be more effective. Implementing a pre-consultation questionnaire can have a profound effect on patient and staff satisfaction. Just here are a couple of reports from staff just since implementing the pre-consultation questionnaire, and I'll give you a few seconds to have a look at those. The scaling of importance and confidence enables us to support appropriate action for an individual's current level of activation. Exploring ambivalence, when importance is low, building confidence through small achievable goal setting, and positive reinforcement of success and the real impact patient changes are having on their health and their opportunities. Our work has challenged historic models of care, which are based solely on clinical indicators of risk, which ignore the contribution the patient can make towards achieving optimal outcomes. Our amendment to Putting Feet First guidelines across Wales places a patient's activation levels at the heart of risk assessment and patient-centred management planning, ensuring the hazard of low activation is considered alongside historical clinical risk indicators. In turn, this has informed our nationally agreed All Wales Podiatry taxonomy of patient need and risk, allowing patient stratification now based on the holistic needs of the individual and not solely clinical historic risk factors. And finally, we have recently raised £46,000 of Public Health Wales funding through the All Wales Diabetes Implementation Group to purchase 10,000 validated patient activation measures for use across Wales over the next year. This will enable us as a profession to develop patient-centred management plans, ensuring validated activation scores to address the patient factors which contribute to preventable crisis. So this is our story so far on how we have taken a value-based approach to measuring outcomes that are inextricably linked to our increasing population need, and specifically and profession-specific KPIs are listed here. We are looking at reducing reulceration rates, improved healing rates, reduced new and follow-up demand, and the reduced frequency of attendance mid to long term. The reductions in waste associated with high DNA rates and CNA rates, increasing clinical capacity in primary, community and secondary care settings, our increased crisis prevention, reduced admissions, increases in safe patient-initiated follow-ups. PIFU is something that is fantastic, but how we can do it safely without knowing a patient's problem-solving ability or activation level is beyond us. Patient satisfaction, a reduction in complaints, incidents, claims, and obviously healthier lifestyles, looking at reduced BMIs, improved exercise and mobility, and increased smoking cessation. So that was a whistle-stop tour. Apologies for not being able to spend a lot more time on each slide, but hopefully that's given some thirst for questions.
Thank you, David. Absolutely great to hear the work that you've been doing. I know that I was sort of, having previously worked with yourself quite a few years ago, it was really exciting to get you to tell you your story. Really impressive to hear about, how you've got staff and people engaged in that process to create people with more independence and that self-management approach. Sure, I've got questions, but I will open it up to people who are listening in. Any questions, please, hands up or put anything in the chat. Wendy, you want to go first?
Oh, yes, please. Cracking presentation, David. Thank you. I find this really, really interesting. My background within cancer rehabilitation, and we struggled with understanding why we had so many people who couldn't attend. The DNA rates were really high, and we noticed that the importance and confidence scaling gave us an awareness of, I guess, that level of activation. We weren't at the time in a position to be able to do a lot about it, but did you find that educational component with your teams, getting them to understand how to tailor their level of intervention? Because people think if somebody's not activated, there's nothing we can do, and we just send them away, don't we? And that causes anxiety because we don't want to send people away. But are you able to expand a little bit on what it means to be able to provide that more tailored approach for folk who perhaps aren't there yet as far as owning their self-care?
Absolutely, that's not a challenge. It's an opportunity when we have patients who demonstrate low activation levels for whatever permutation of importance, confidence, knowledge and skills. Through training, we now have a workforce that looks at each of those areas specific to that particular individual to be able to inform next steps. No planning is undertaken without considering those 4 areas in patient. We can't risk stratify our patient in Wales as a profession, as podiatrists, without considering those 4 elements now, alongside the historic clinical risk indicators that we were all taught, we're all so comfortable but shackled to. It's a case of ensuring that we get buy-in from the workforce to understand that these things, a patient's problem-solving ability, can be changed, can be modified. Activation can change and should change over time. It is normal. It is absolutely normal for everyone. And the best way to prove that is hopefully by us looking at ourselves and what we currently do, even though we have the knowledge and skills, and reflect on our own importance and confidence.
I guess just one really quick question, if you'll bear with me, Gethin, is what training did you find most helpful for your team?
Okay, we started off with the Health Foundation co-production toolkit and the resources available through the Health Foundation. They are really, really good. Somebody that is a cult leader then, such as myself, who's immovable on the importance of activation as the panacea for all ill, just driving that forward with a team, building champions as you go along, and really chipping away in order to embed it It has to be daily business and bread and butter business, and it has to be factual. It has to be data-based. We have to be able to demonstrate to our patients, to our staff and patients, that this is not just some whimsy. This is why we haven't got it right in the past.
Thank you, David. Peter, you've got your hand up there. Do you want to go next?
Yeah, thank you very much. Thank you, David. I always love hearing you speak. I'm always really inspired by you. I think I'm firmly in your cult. I think this stuff is, I would say, naturally easy for AHPs. It's the way we work. We find it easy to do this stuff. I think I'm interested how we start to get other professions to join our cult. Because that paternalistic approach to healthcare is a problem, and I don't want to go beating up my other professional colleagues, but like within the medical profession, it's a really difficult one to kind of overcome. And of course, we don't work in isolation, do we? We all work together as part of the MDT. And how do we kind of convince others, really? I almost feel like we've kind of won the argument with AHPs, but how do we kind of get that? How do we get the others to join our cult? What are your thoughts?
I think we need to commit to using the language and using the language more on a daily basis when we're with our colleagues. I think when we are providing information to our medical colleagues in particular, when we're signposting and referring, I think we need to share what intelligence we have on a patient's activation levels and get them questioning and open ourselves up to support them to join the bus and be on the same journey as us and use the same language and really hard sell the benefits to them. Not just from an outcome point of view, but from a governance point of view. I shared the Hcpc duty of care. It's similarly a medical duty of care. It's a nursing duty of care. And whilst it's very reassuring sometimes to write patient non-compliant or patient non-concordant, I think it's selling to our medical colleagues how much deeper they have dug their duty by writing that. They feel reassured by it, but actually it's opened a duty. It's identified something needs to be done, something quite spectacular needs to be done because this patient has not engaged. This patient, now we know this patient doesn't have the problem solving abilities to do so. So I think it's more about pressing on and using this language of activation.
Thanks for the question, Peter. So Laura's got a hand up as well. Laura Ingham. Laura, do you want to go next?
Yeah, hi, thanks. Great talk, David. And as you know, I'm a convert as well. Really interested always to hear about patient activation. I just wondered if there was any, I know that Public Health Wales have been scoping to see if this measure could be more accessible to other services and teams across Wales. And I wondered if anyone had any updates in relation to that, because currently, as I see it, it's not something that's very accessible, unfortunately, for sort of wider use.
I think it's very expensive to be able to use the validated measure. However, what we've talked about today, the majority of our journey has been based on the rude and crude importance and confidence for which you do not need any validated licence. However, hopefully our national project in podiatry and orthotics that's funded by Public Health Wales now will generate the data to be able to persuade more investment across Wales, hopefully akin to the investment by Public Health England, where the patient activation measure is available to all, for all patients.
Yeah, thank you, and thank you for continuing to sort of fly the flag and keep that on the agenda for Welsh Government. Thank you.
Great, thank you, David. Can I just ask, just thinking about if you could look back at what you've achieved, if you had a wish list of how things could have gone a little bit easier, or if you knew what you knew now, what would you do differently? Are there any particular tips, especially for people who might be thinking about, embracing a new format of how they go about their working roles and their services?
Oh, yes, really good question. I think the most valuable thing would be to start small. I think model the behaviour, small, manageable baby steps, particularly with the workforce. I think what we did, and I have to take full responsibility for this because I was easily and quickly converted. I went a bit too heavy, I think, with the training with staff. It was too much at one time. The toolkit was far too great. And I think that initially was a bit counterproductive and set me back a little while with staff. I think if I'd had my time all over again, I would have just introduced why we need to do things differently using the data that wasn't available to me at that time because we hadn't undertaken things like the root cause analysis. Let's model the behaviour. We don't expect patients to do anything that's beyond their problem-solving ability. So let's look at our clinician activation measure, our therapist activation measure. And there is such a thing. I've talked about the patient activation measure, the patient activation measure, or PAM. We need to be looking at the CSPAM, which is the clinician activation measure. What capacity is there currently within our workforce? What importance and confidence? And it is just beautiful to see that you've modelled this behaviour today, because at the start of this, you've already asked the question and scaled importance and confidence in relation to the subject matter. So yeah, start small.
Yeah, that's great. David, I've got a few more questions for you, but I'm conscious of time, so I'm going to leave that for another time. Particularly interested in the introduction of the pre-consultation questionnaires. I know some people find that quite challenging to get that implemented, so well done, and be good to hear more about that in the future. Okay, Amanda, are you all right to come in next? So Amanda Atkinson is the head of paediatric occupational therapy in Swansea Bay Health Board. A category winner for Leadership and Change Management Award at the AHA Wales Awards 2019, an overall winner. When I was introduced to Amanda, I was really impressed with the discussion about the MDT approach, but primarily bringing the needs, identifying where the needs were for the people that they were seeing, and bringing their care to them, or that support to them, as opposed to that traditional maybe waiting for that appointment that you'd have traditionally in 6 months' time, and so on. And also being able to do that virtually in the community during the pandemic. So I'll hopefully I haven't said Amanda's talk now, but I'll let Amanda take over. But thanks for that, Amanda.
Thank you, Gethin. Hi all. Thank you for that introduction. I suppose I'm here just to talk about how we've thought about value, and really just to say operationally how we've embedded it into our service and how we continue to try and embed value. So the first thing we really thought about is what is value? How can we maximise the value, and who is the value for? We've all used many outcomes in the past, and my team had been using some clinical outcomes and some experience measures. But what will we do? We first thought about who was benefiting from the service and who needed to benefit from the service to improve the value for all. So that for us, it was very much about who is using our service. So it was for the children,
and young people. It was also for the families and carers, but it was also for all the stakeholders that were around that child, that were supporting that child. So it was, what value were we bringing and what value were we measuring for all? And also what I was really mindful about through the whole journey is about what value were we bringing to the staff? What value were we bringing for the team? Because it is quite clear that without a team that is valued and without a team that feels that what they're doing is really showing value for the service user, then we have that lack of motivation. And we've just heard David speaking much about activation, and it's also, I feel it's we must be very mindful of that with our staff also. Also, what I was really mindful about is that we really needed to have a strong evidence base for everything that we were doing. And like everything, it's about weighing up the cost to the social benefits. So as a service, what we did initially, because when we started the transformational change for our service, we had waiting lists that were kind of out of control, like 1.5 years, and they had to be within 14 weeks. We had quite a lot of complaints from parents. We had lack of engagement with our service users. We weren't really focusing and asking them exactly what the population need was. And the outcomes that we were obtaining, we weren't really evaluating them. We weren't really thinking about who the value was for. So we stripped back and we had a look at the data, and we found about what things we were doing that were most costly. And one cost to us was very much about time. And then we stripped back and looked and tried to work a lot more prudently. So we started to do what was only necessarily, and started only doing what was actually going to embed value for everybody. And also we tried to eliminate all those things that really didn't have a strong evidence base and weren't bringing value. And I think that exercise was really tricky, because as therapists, I think we just firefight. We're so busy all the time, and we just go ahead doing what we are doing. So have that time out to actually think about that value-based approach was really, really important for us. So we looked at the quadruple aims and all other government drivers, and we knew that we wanted to enhance that patient experience. We knew that we wanted to improve population health. And what we were doing is just sitting back in secondary care, just managing this waiting list. And we weren't really getting out there in the community. We weren't really investing in our population. And we didn't actually know what our population needs were. We knew we wanted to reduce health expenditure. So we knew that we wanted to get rid of that luggage that we didn't use. We kind of packed for this 2-week holiday, and all we really needed was to pack for a weekend. We just wanted to get rid of all the things that we could get rid of. And what we really wanted to focus on our staff as well. Staff were tired, staff were unmotivated. So we really knew we had to work in this area also. So we had lots of drivers and lots of visions, really. We want to ensure that we try to stick to that no wrong door. Co-production was huge, and we just heard David really talking about that. And we made sure that all our staff were trained in co-production and also motivational interviewing, which really complements this. We really focused on doing a lot of training and work with our team, looking at what at engagement of the service users, really ascertaining what the main concerns was, and being very strength focused and very person centered, making sure that we reinforce success, and ensuring that we had that just right challenge for the child and young person, also for the family, and also for the stakeholders, which included many sort of teaching staff. We really tried to support that sort of language of activation, and we do this through every appointment, trying to make every contact count. Partnership working and collaboration was essential. We work really closely with our MDT colleagues in paediatrics, and I manage occupational therapy, but also our physiotherapy, dietetics, speech and language therapy colleagues. We all work very closely and work in a similar model. Accessibility was really important. So without this value-based healthcare approach, we weren't able to shift our practices and to allow us to be more accessible. So that was having open access referrals, getting out there in the community, providing advice clinics, having advice lines, the use of lots of other digital, so social media, vlogs, websites, just making sure that our practice were being embedded, really. Ensuring partnership working across sectors as well was really, really important. When you're working with children and young people, you can't work in isolation in health. We really needed to work with our social care, our third sector, and also education. Prevention being very, very part of the rehab agenda, and this was really, really important. Again, we didn't want to sit back and firefight. We wanted to be out there preventing, intervening early, which we know research tells us it is important. Empowerment, we've heard quite a lot about that this morning, and that was really, really important. And again, I can't emphasize enough about empowerment for all. So empowerment for and growing confidence in our staff to enable them to use this value-based approach, and also empowering all stakeholders around that child and family. Asset mapping was essential for us to really flip on our heads and ensure that what we were doing was very different and was very much person-centred. We had to think about demand and capacity. So asset mapping and looking what was already out there was really important. So those community assets. Network building was really important. Building strong relationships up. Demonstrating the value in what we do enables other people and drives and motivates other people to want to embed it into the culture and the fabric, for example, the fabric of schools. And that sustainability was really important to us as well. We wanted to try and build strengths and structures within the community so that we had parent champions and we had community groups that were able to continue to support that change. So within our service, we did a lot of visual mapping. I put this slide up now as used as a bit of comedy, I suppose, but we did really just have this island. We had this vision that we wanted to get to, and we wanted to populate it. And then we had to think about what kind of mechanisms we do to get there. So examples of adding value then for us would be that we used a lot of focus groups to establish needs. So we did focus groups for children, young people and parents and teaching staff. And again, a lot of liaison as well with our MDT colleagues. We knew that we wanted to be included, an essential part of that very early intervention. So engaging in sort of pathfinders work across Swansea Bay. We managed to source some primary care funding to try and get to that first point practitioner again, that preventative approach. More investment from via service level agreements with our local authorities, Swansea in Swansea Bay. We managed to get more investment again, and that was due to that network building and showing the value of what we can do. Improving joint pathways and processes. Working collaboratively, so working holistically. For example, we've got a project working with wellbeing workers from CAM services within schools, and then again using them to embed the value of therapy. Multi-agency preventative groups, we really put a lot of time into this. So again, working multi-agency is essential. I mentioned about open access, and I've mentioned about the third sector, but enabling us to, once we've added this value, what we basically did is, instead of wasting all this specialist resource, wasting all this lovely ice cream, we were able to flip that on its head, really, and ensuring that our universal and our targeted approaches were actually supporting a much wider number of children and families within the community. So how do we continue to measure value? For me, it was about establishing what value is and continuing to establish what that value is, because that value changes. Again, I know that David mentioned about at the activation stage and establish what is important, but that I will re-emphasize again, that is so important with children and families, and particularly working with children, because we need to see of what value is to the child, but also what value it is to that parent. So it's working with that whole family unit. So embedded value in and making those service changes is really important. Evaluating the added value and demonstrating that value to the stakeholders in order to get more investment in staff and also in investors, to enable that added value to continue. And this is cyclical, and it is ongoing, and we need to continue to measure that. We continually look back at and evaluate it against the quadruple aims. Each segment is really essential. We've had some really lovely feedback, and we do measure these via a number of outcomes. But again, just reiterating what was said today, it's very much about building importance, building confidence. We continually use prems and proms, and patient stories we feel are really, really advantageous in getting our messages out there, really. So by adding the value then, what have we been able to do? It has been an incredible team effort. But we now have instead of firefighting and just looking at waiting lists, we're able now to have our waiting list very much under control, which is something that we have to report back to Welsh Government, as you know. But because now we've flipped that ice cream back on its head, we spend 50% of our time doing prevention work. So we're out there doing supportive work with children and young people and their families. We have got that improved commissioning of services, which again helps with our demand and capacity. We have much better team cohesion. We have much better well-being. And we have really good patient-related outcomes and experience measures, and these are co-produced. And we have far better leadership. We have very much compassionate and inclusive leadership. We have leadership on all levels. So thank you from myself and all my team, and I'm happy to take any questions.
Thank you, Amanda. Just waiting to see if there are any particular questions. My question would be about what particular resources or did you need really? Or did all this come from the OT core staff that you had there and the MDT, or was there any particular other services you needed to go and be friends with?
Yeah, so it really was looking about mapping our assets within the community, was definitely, and that network building to know what was out there that could support us. But for me, it was very much about working with my team and working with the MDT colleagues really to look at what was important and what the population need was, in order for us to manage our demand and capacity so that we could then start in to do that preventative approach. So it was a lot of training within our team.
Wendy?
Yeah, hi Amanda, thank you. Always really inspiring hearing about the work that you've done. I'm really interested in you it was at the end of your presentation you were talking about leadership at all levels. yesterday we had a session around leadership, and I think we've got this burgeoning idea of clinical leadership rather than management necessarily, but we've also got students and new graduates and support workers taking ownership of leadership elements of a role. Now, in the past, we've always thought you have to be at a high level of banding in order to be a leader. I'm interested in how your team felt about owning some of that leadership responsibility. Was it something they were hungry for? Was it something that they were a bit nervous about?
I think mixed feelings really, Wendy. Yeah, I think we did a lot of work getting to know our team, getting to know the skills of each member of the team, so that we really knew which members of the team were those true leaders, and those that were a little bit more shy, really, but and ensuring that every member of the team had different skills, and they were all really important to make that team. That skill mix was really important. So we were very, very supportive of each other. And so now that we do have leadership within our assistants and our techs and our admin team as well, and on every sort of grade. But we try not to look at it as in bands and hierarchical. It is about supporting and using those skills and being leaders with that skill. We have some amazing techs, and I think in therapy we can all agree that sometimes our techs are far better than, I know they've got far better skills than what I have. I know that I have band 7s in my team, they're far better skills than what I have. So it was really empowering them to take ownership. And what we also have done is we've done some so a lot of feedback from team, and we've got our other team members to feedback on the progression of their skills, which has been a real confidence boost. And we've had some really lovely feedback. For example, I have had a band 7 who is absolutely amazing, but previously she was extremely unconfident, wouldn't present, wouldn't do anything, and now she'll put her hand up to present in a conference, which is massive. And then I did have one tech within my team, which was a really tricky character, and I found her really tricky, really. And it was hard, if I'm really honest, for me to respect her because she was such a tricky character. But I knew that she had a fantastic skill set. So I put a lot of investment into her, and now I completely respect her, and she does myself. So it was about earning and having that mutual respect. So yeah, a lot of investment into staff.
And just quickly, because I'm conscious of time, but were there resources or tools or training packages or anything that helped you to do that? Is there anything that you could recommend to others who might be sort of sitting on the call thinking, I'm in the same situation, I've got those same sorts of characters in my team? Is there something that perhaps we could share on the webpage as far as links to some of those resources that could help others?
Yeah, I can share the resources that we used. Yeah, they weren't anything new or massively innovative. It was just looking at a skill set and team cohesion. Yeah, and then we did an awful lot of fun things. We really did. We definitely did introduce the fun element and the well-being element within our team and across our multidisciplinary teams in paediatrics as well.
Brilliant. Thank you so much.
Thank you, Amanda. So, and I appreciate people might need to leave now. So if you are able to stick around, we're just going to quickly finish off with repeating those similar questions we had earlier. Lauren, I don't know if you can bring up the importance of confidence scaling again, please.
Yeah.
I think we're going to obviously run out of time with regards to getting people together in the groups. We won't do that. We will keep the Jamboard live though on the web page. Is that right, Lauren? So people can still answer those questions. Is that?
Yeah, that's fine.
Correct. Yeah. So what we'll look for is, so first question, just if we can get you to have a think about how important you feel the use of value-based outcomes are, having listened to those two inspiring discussions. Okay, so we've seemed to have moved up generally to quite a high score, which is great. That importance is still quite high. And then can we move to the question about confidence? So bear in mind what we spoke about, particularly what David spoke about earlier. And I think it's okay to say that if our confidence isn't quite there, this is something we need to be building on from that scaling point of view. Even if we're taking that, what's that next jump to the next pebble? What are we looking to do? David spoke about doing things in small stages. But hopefully where there's a need, we can help develop additional resources or look at putting people in the right direction. Okay, so that confidence has actually moved up there. I think we were looking at around a 2.5, weren't we, at the start? So that's great to see that moving up. Absolutely fantastic. Okay. If people can stick around, is it possible to put the Jamboard up, Laura, now, or is it easier to put it as a link?
It's entirely up to you.
Okay, so just quickly, what we're looking to do for the people that have invested time to come in today is we're trying to look at how we can take this forward a bit more. So thinking about what would increase your confidence in the use of a value-based approach. So this is a slightly different setup. Sorry, you need to hit that link and write your answer in there. Lauren, you might want, is there anything you maybe would sell that a bit better than how I just described that?
No, the link's in the chat bar, and if people click on it, then it will come up on their own screen, so it'll be much easier to read.
Yeah. And on the left-hand side, we've got the toolbar. We recommend using the post-it note, which is the little white square there, or the text box for you to input your answers.
As I said, this link will be available after the session as well. Okay, and appreciate this to be built up over time now. So what we'll do is we'll definitely store this information and use it as we're moving forward. While people are still typing away, just a big thank you to David and Amanda for their time this morning. Absolutely inspiring to hear. And we will keep. We'll look at these. We'll look at what the discussion came up in the chat as well, and hopefully look at making some additional resources to support this conversation.